Assalamu alaikum. Thank you very much. Special thanks to Prof. Sulaiman Mayouf and also the organizers of the Saudi Society for inviting me for this talk. I have no disclosures for this talk, so this is going to be a year in review in lupus. So obviously, as you all know, searching for relevant terms, I looked at the publications in 2023, stopped all the way until January 20th. That was the deadline to submit this talk. I have excluded case reports unless they were genetic case reports revealing important variants. I excluded the review papers and preprints and came to 124 articles in 2023 related to childhood lupus. After classifying them by theme, methodology, applicability, practical knowledge, meaning more emphasis on clinical and translational rather than basic science, and also respecting the allotted time for the talk, we got to 38 articles, and I already apologize in advance if there is any paper or a study that you would have liked featured that's not featured today. So we'll start first with lupus nephritis. As you all know, lupus nephritis is considered one of the most important morbidity and even mortality in childhood lupus. This study from North America had a nice collection of lupus nephritis patients, 382, and they looked at the trajectory of lupus nephritis in 2 years, and they found at 2 years there was only 57% complete remission. This echoes what we already know about the remission status in lupus nephritis and how difficult it is. They looked at different factors to know which patients reached that remission status, and they found that severe kidney involvement was the most important factors at the beginning. The induction treatment actually that was used in those patients, in the 382, did not really impact the outcome, which was very interesting. What about patients who present first with AKI, severe AKI? This study looked at 59 childhood lupus nephritis patients, and they found that around a third of them, or a little bit more than a third, did not recover at all from their AKI, or the acute kidney injury, and developed renal failure. So when looking at the risk factors for renal failure, I feel like a lot of these are intuitive that you probably already predict. Severe tubular atrophy and interstitial fibrosis with a NIH activity index on a renal biopsy of more than 4 were very strong factors for development of renal failure and really needing, obviously, other methods of renal replacement therapy. The AKI duration itself in those patients did not really matter. Another study looked at what about those lupus patients that do not develop lupus nephritis at the beginning, but then they end up having lupus nephritis later on down the road. And in this study, basically, I don't think you see my pointer. So in this study, if you look at the survival curve, you'll see basically that in this one, there is different categories of lowest, middle, and highest. This is related to double-stranded DNA. So what this study looked at first is what are the risk factors for those patients developing lupus nephritis later. And these are generic risk factors, I feel like, in my eyes. They're not necessarily something that is out of the norm of what you would predict, but they found that double-stranded DNA and ESR levels in the follow-up periods were the most important risk factors, and this is how those with the highest double-stranded DNA had definitely more prediction of or more development of lupus nephritis later on. This is one of the largest studies of lupus nephritis in the past year, where 27 centers, over 1,000 patients were collected with childhood lupus nephritis. And the question that's always in our minds, what is the rate of chronic kidney disease in lupus nephritis in childhood population, obviously? This is only one study. I think there is probably a lot of conflict on what is the actual number, but this study, which is a big study, found 5% of patients had or developed chronic kidney disease ultimately. When looking at the risk factors in these patients, they found that the risk factors were proliferative lupus nephritis with odds of 2.8 times, hypertension, and then also they found clear evidence that antimalarials helped with these patients with the development of CKD. So this is another evidence that is helpful in our practice. Now, what does make lupus nephritis patients relapse? In the previous study, I showed you that there were risk factors for some of those population in a smaller study. This is a bigger study of 20 years. There's a lot of survival curves in this slide, but basically they looked at those patients who in 5 and 10 years developed lupus or developed a flare of lupus nephritis, right? So to just summarize, the first curve at the top left basically shows you those above or below 13 years of age at the time of diagnosis, and they found that those at older age, more than 13 years of age, those with complete remission at 6 months, And then those who used MMF, which is top right, MMF versus azathioprine, actually all had less chances of relapse, which is very interesting. I think some of those, again, are intuitive. We think of MMF and azathioprine and maintenance treatment as more or less equivalent in some papers, but also this one just shows you that MMF is probably superior. When it comes to biomarkers of lupus nephritis, there were several studies. Obviously, it's just hard to sift through all of them. But just to summarize all the different biomarkers based on activity, damage, and renal relapse, and I'll show you a few of the ones that I think are notable. This study showed, it's a very small study, but actually has significant power to the result that they found. This is in urinary soluble CD163. I'm sure some of you have already heard about it. Was done in adult studies. So this study, they found that healthy controls, it's in green, inactive lupus without renal, in blue. And then in orange is active non-renal, so active lupus but with no renal involvement, and then active renal, which is in red. And they found that those patients had much higher level of urinary soluble CD163. And then they also correlated that with interstitial inflammation and fibrosis on their kidney biopsy. So it's a very consistent marker with the level of disease in the kidney biopsy as well as with the activity of lupus nephritis, as you can see in the ROC curve with very high values. This is another marker that I think might be more relevant for non-renal disease. So the initial study looked at it for renal disease, but they found different results. So serum soluble B-cell maturation antigen is actually the receptor for the BAFF, which we already know is related to the drug belimumab. So this is the receptor for it, and they were trying to see if this marker, if measured in the blood, would actually be helpful in identifying certain subsets of lupus patients. And they found in the left graph, when they compared healthy, untreated, and treated, and then in the right graph with the different SLEDAI scores, that those levels were highest in those untreated with higher activity. But they associated only with immunological, hematological markers, not with renal markers, so this is not necessarily a marker for lupus nephritis. And then finally, with the biomarkers for relapse, this study is an extension on what we call the RAIL score, is a score that developed by Dr. Hermina Bruner in Cincinnati. The score is basically a composite of different biomarkers, NGAL, ceruloplasmin, adiponectin, so on and so forth. And the score was already associated with high activity of lupus nephritis. In this study, what they did is they looked at those patients and their scores in blue. So left group is complete responders, partial, and non-responders. So they all had a certain level of RAIL score at the beginning of their disease consistent with their lupus nephritis activity. And then looking at the remission criteria, you need to have the stringent criteria that are listed here, like NIH Activity Index less than 4 on repeat biopsy, but not all of them had repeat biopsy. Obviously, less proteinuria, less sediment. And they found that those patients with complete response, they had, if you can see the gray bars, they had reduction in their RAIL score. And those who did not respond, they had much higher RAIL score. So basically, this is just another indication that potentially the collection of these biomarkers could be helpful in looking at the relapse rate in lupus nephritis. This is a big study that probably a lot of you also have seen it, maybe featured in one of our previous conferences. This is out of CARA, the North American Pediatric Rheumatology Group, and they looked at the NIH versus Euro-lupus protocol when it comes to cyclophosphamide for induction of treatment. There's a lot of stuff going on here, but what basically you can see here, the 12-month renal outcome at the results section, Euro-lupus versus NIH cohort, they pretty much had similar odds. So in conclusion, in this study, which is granted it is a retrospective study, it is not a trial, they found that there is no major difference between doing Euro-lupus versus NIH protocol when it comes to achieving induction. What about cyclophosphamide versus MMF? Again, there was a study that was published also in the past year that looked at it retrospectively. Again, these are all limited studies, but this is another evidence that can show you that in the right study, there were 33 lupus nephritis patients, half of them MMF, half cyclophosphamide. They pretty much had similar rates of response to both treatments, and they tolerated the medications the same. So again, not the highest level of evidence, but these can be maybe supportive in your treatment. This, I think, is a very interesting study, although it's a small study. But I'm sure you all have known about the addition of calcineurin inhibitors as a combination treatment for lupus nephritis induction and potentially maintenance. The first study, I think, came out in 2017 from China that showed that there is superiority of this combination, steroids, MMF, and tacrolimus, to compare to cyclophosphamide, which was, I think, was mind-blowing. And this is a study that came out also of China that looked at pediatric outcomes. So what they did is they had 36 lupus nephritis patients. 8 of them were naive and some were refractory, and majority of them with class 4. I keep pointing at the screen, but there's no pointer showing up. The majority of them had proliferative lupus nephritis, and they followed them for a decent amount of time. The conclusion is that they found that this combination treatment, which is called multi-target therapy, improved the complete remission rate in both naive and refractory. The figure on the top right shows you the 24-hour urine protein and how it reduced significantly in the first 3 months. And then the bottom figure shows you how the partial remission, which is gray, went down, but the complete remission went up. So this basically just supplements that this method of induction treatment is potentially a plausible method, but obviously this is a small study, so we need more data. There was some side effects that were reported with this regimen, but there's no comparator group to see if the side effects were significant enough or not. But at the bottom here, basically, you can see that when using calcineurin inhibitor, tacrolimus, other medications, cyclosporin, you worry about the kidney function. So you don't want to treat and then damage the kidney. So in this study, in 24 months, there was no decline in GFR. So that was reassuring. In terms of B-cell therapy, I didn't find much in 2023, but this is a study, again retrospective, that showed 14 children on rituximab. And as you can see here in the table, complete remission rates were increasing as the time went by. So here there is a favorable response of rituximab in those patients. There's really not much to conclude from this study, but what I was interested in more is belimumab. So belimumab is, as you know, approved for lupus nephritis in adults, right? And the BLISS-LN study is still trying to kind of see what the outcomes would be for children. So this is still an ongoing issue. I'm sure there's people here in this room who have used belimumab for lupus nephritis, and it would be interesting to have a discussion at the end on what your experiences have been. But in terms of systematic evidence, there is not really strong evidence for using belimumab in childhood lupus nephritis. These two studies, at the right and the bottom, they just looked at belimumab in lupus in general, in childhood lupus, and they found in the right one how the steroid dosing that the patients need decreased with time, their SLEDAI score went down. Again, another study here, a very large study, 193 childhood lupus patients, again, decreased in the activity and the SLEDAI scores, but there is no mention of lupus nephritis. In that one study, which is coming out of North America, they found that one patient who had class 3 lupus nephritis ended up having a flare while on belimumab, and they had to be switched to cyclophosphamide and rituximab. So I think we desperately need this evidence because, as you know, the limited number of medications that we have, and obviously trying to get approval for medications always delays the problem or delays the outcomes. What about interferon blockers? So now I'm kind of switching gears and talking more about therapeutics outside of lupus nephritis. This is an interesting study. As you all know, anifrolumab has been approved for lupus. There is not much evidence on its efficacy for lupus nephritis or neuropsychiatric lupus, but there is strong evidence from the clinical trials that we've seen about its support or about its efficacy for skin disease. And this is a nice paper that was published in JAMA of 7 adolescent patients with very refractory discoid lupus. The lesions improved and the CLASI score improved even within the first month on this treatment. And 1 out of the 7 patients just had recurrent herpes simplex reactivation, but otherwise they all tolerated the medication really well. Now, continuing to talk about therapeutics, this is probably the only adult study that I included in this talk, and this is the BRAVE trial. This is just to kind of remind you of what happened in the past year with the BRAVE trial, or JAK-STAT. So the BRAVE trial basically looked at JAK-STAT inhibitor, specifically baricitinib, in systemic lupus. So this is obviously an adult study. And they had favorable responses. You can see here the primary outcome, reduction of SLEDAI and the SRI-4. But their secondary outcomes were not met, and they were a little bit more stringent. So what they did is they wanted to just re-emphasize the point of baricitinib in lupus, and they repeated BRAVE. So the second BRAVE actually was a disappointment because the outcomes were not met, even the primary outcome was not met. As you can see here from the survival graph, that basically patients did not really do better than placebo, which is it kind of raises the question, again, it would be nice to discuss with all of you your experience of JAK-STAT inhibitors in lupus if you are doing them off-label. I will not spend time on this slide. This is just the main principles endorsed by press for treat to target, as there is a talk on lupus treat to target. But what is important to maybe discuss or just kind of reflect on is one of the targets that people are starting to use is the LLDAS, which is the Low Lupus Disease Activity Score. It is a very stringent score. It is summarized on the box on the right. So you really need to have this level of control for you to call a patient LLDAS or they have reached the LLDAS. In this study, 230 patients took them a year to get to LLDAS. But when they looked at the renal ones, which are in the green, they did eventually come to LLDAS, but they took a little bit longer time compared to the non-renal. And then this another patient also from North America with 165 patients that even with LLDAS, they looked at the damage index at the end. So even those patients who did get to the low lupus disease activity ended up still having high damage if they had renal involvement. So it really just kind of prompts your thinking, like what target do I get to in lupus and which one is the best? One slide about infections. So there were 2 studies about infections in lupus. And the first one just summarizes to you the different causes of mortality and infection, sepsis being the highest. And in that study, it's 1,528 patients, a very large study. And neuropsychiatric and chronic kidney disease were the main risk factors for the development of, or for the mortality from infection. This other study had a smaller number of patients, 98, and they noticed that the majority of the infection happened in the first 6 months, which is probably intuitive because in the beginning of the illness, you actually use a lot of immunosuppression. And these were the risk factors associated with infection, such as SLEDAI more than 10, nephritis, and lymphopenia. Now, switching gears to talk about genetics, right? So I'm sure a lot of you have looked at this figure from one of the studies summarizing the pathomechanism behind genetic lupus in different categories. Here, I'm just going to list very briefly and quickly the different reports that come out in 2023 related to genetic variants related with lupus. So this study was published by Rossano. It reports on one patient that had a heterozygous mutation in Tregs. And Tregs, as you can see, it's part of the nucleic acid sensing protein that is important in managing the nucleic acid antigens. And this patient only developed refractory cutaneous lupus, did not have any other manifestations, which could be expected, Tregs associated with chilblain lupus. And this patient actually had a successful treatment with baricitinib. Another report came out showing the classic skin ulcerations that I'm sure a lot of you have seen in C1q deficiency patients developing lupus. It's a 3-year-old male, classic age, classic findings, and responded to fresh frozen plasma. Another variant came out in the literature in the past year in a patient who's actually a 13-year-old male with Noonan and developed classic case of lupus. Maybe I'm not listing all the manifestations here, but they did have all the classic antibodies and the classic manifestations. And this is the 14th report. 13 reports previous to that actually showed changes or variants in RAS MAP kinase pathway and its relationship to lupus. So I think we're going to learn potentially more and more about how T cell maturation and how the pathway of RAS MAP kinase affects and leads to lupus. And then this is another also interesting study that was found. So the protein is called PAXN1. It is considered part of I put it in that category, it was not listed in that paper. So it's part of the nucleic acid sensing. So in the normal condition, nucleic acids presenting within the endosome are processed, and then the signal transduction gets to the nucleus for you to have the appropriate cytokines. Paxin acts kind of like a brake system that reduces that. So this 14-year-old patient had mutation in that protein, which led to removing the brakes and led to higher level of type 1 interferon production. And indeed, the patient had classic findings of lupus, and they also just kind of had a collection of patients, including this patient, to check if they had PAXN1 expression and how is it associated with type 1 interferon, and they found a close connection in these segments. The patient was treated with steroids and azathioprine, and he's doing well. And then finally, this is just kind of like a brief mention of the inflammasome and how it is related to lupus. The picture here just shows you NLRP3, not NLRC4, but it just shows you how this inflammasome can be connected to different parts in the immune system that could potentially lead to lupus. And in this study, in this very unique report, the mother had a heterozygous gain-of-function mutation and had classic lupus findings. And then her baby also had the same exact mutation, but developed MAS, which we already know that NLRC4 has connection to MAS. So in this one, the baby developed neonatal lupus MAS and unfortunately died. And this family basically showed upregulation of NF-kappa B interferon signature in addition to the classic inflammasome IL-1 beta and IL-18 signature. This study is an amazing study by Prof. Mayyouf and his group, showing you a really large collection, a relatively large collection of monogenic lupus patients. And in this study, what they have listed or outlined for us is they compared in a case control format a monogenic lupus cohort of 27 patients with sporadic lupus patients. And they emphasize here that monogenic lupus has a more equal female to male ratio, more consanguinity, younger age, more failure to thrive, more photosensitivity GI and ocular, there's more recurrent infections, and consistently low C1q and more antiphospholipid antibody. The monogenic lupus group had higher disease damage and higher mortality, given the fact that probably their genetic defects related to risk of infection as well. So that was something that's really nice to see. But when you look at other genetic studies and other cohorts, they could potentially report something different. Granted, it's different methodology. So this is a cohort from the UK. So what they did is they had almost, I didn't list the number, but it's almost 400 patients of lupus in general. And they focused on rare damaging variants, and they wanted to look at the burden of those damaging variants. They found out eventually there was 12 patients who eventually developed classic lupus findings, and they potentially had some relevant variants. The rest of them carried variants that were potentially causative or relevant, but not necessarily causing the disease. And the majority of those variants had anything to do with nucleic acid metabolism and processing. They found that they divided the patients into genetic lupus and non-genetic lupus based on the damaging variants. And they found that those patients had actually less disease activity and damage, which kind of conflicts with the other reports. But I think it has to do with the population that they have selected for and the fact that these populations don't necessarily have monogenic disease. All right, I will skip this one. It's pretty much the same, just studying the genetic burden in those lupus patients. I think we need to focus more on understanding the immune pathways related to lupus rather than just kind of like listing them. In this format, they did that, and they found that there's higher genetic burden in lupus patients. This is an interesting study from the UK, basically looking at different cytokine profile and gene signatures. And I won't go into the details here, but what I will just turn your attention to is that there is different biologic profiles. The blue is low biologic, high biologic in red, and then mixed. And this is, I think, is a nice gateway study for further work into trying to stratify our lupus patients, because we cannot just lump them into all one category, and we need to understand them biologically. And this study is, I think maybe I should move forward faster. Okay. This study is just another unique study that they had 900 patients, and they found this risk variant for osteonecrosis. Again, if any of you sees osteonecrosis on a regular basis in your lupus cohort, I think it would be interesting to see if this is something that can be replicated. And then just a little bit of mention in the Apple trial. I think there's going to be probably more to hear about this trial and the outcomes of the studies that were done in this trial, but just turn your attention towards risk factors in atherosclerosis. And finally, in neuropsychiatric lupus, 2 studies found that antiphospholipid antibodies and CSF neopterin were very good biomarkers. So those are things that maybe you could potentially look more into. And then finally, this study just kind of looked at whether there is actually initial activation of inflammation inside the brain. And again, this is a nice study that potentially is going to be followed by more and more investigation into the microglia as, you know, starters and initiators of inflammation in neuropsychiatric lupus. Granted, this is in mice studies. So I will stop here. I hope that you had a little bit of kind of summary of the different studies that came out in 2023, and looking forward to more in the next year. Thank you so much.
Thank you so much, Dr. Najla. We have 3 minutes before starting our next talk. Dr. Najla, if anyone want to ask Dr. Najla? If you have any question, you have?
Thanks, Najat. That was really very great overview. I'm sure you spend a lot of time reading all these interesting papers. I'm just interested to ask you regarding the fancy biomarkers that you mentioned, either in the urine or in the blood, as a predictor for lupus nephritis, for example. I know, and correct me if I'm wrong, the majority of these biomarkers still research lab. Do you know any clinical lab doing that? Did you cross any paper that any clinical lab are doing them? And I'm also interested to know if your institute or anyone in Saudi Arabia doing these biomarkers, because actually my research team, I'm pushing to start do these biomarkers, and just want to hear from you.
Yes, thank you so much, Dr. Abuthayna. So, for example, the rail biomarker that I worked on when I was in the States, it actually has a patent. So it was actually developed to be rolled out to clinic. It's still in the process. So even now, it's still used purely as research. And I think the same thing, if you look, for example, at serum CD163, is a very, very strong, and you will see a lot of reports. I think it's very reproducible even. I feel like it's a very, promising biomarker. As far as I know, I don't really know if someone is doing that on a clinical level. I feel like maybe if you ask people in Europe, they might give you a different perspective. So I think it would be interesting to kind of see those who practice in Europe if they have a different. In my institution, so far, we don't have any of those kind of new biomarkers or anything. We're still in very, very young in the process of finding new biomarkers. Yeah.
Okay. Thank you so much, Dr.